Good afternoon, everyone. Thank you for joining in today for the half-day release session on diabetes and endocrinology. What we have today for you guys, I'm just going to be showing you what we have. So this is, if you can see my screen, we have quite a good and interesting program for you. We have an invited lecture from a man of extreme importance and repute from India, Professor Vermani, an expert on diabetes, who's going to be talking about pre-diabetes and tell us the vagaries of it, and dealing with some key issues, and I'm going to be asking him some key questions at the start. This will be followed by case-based learning following the journey of a patient with diabetes, which should be interesting, by Dr. Smita Thakur, who is a GP with special interest in diabetes locally. We'll then have a short break. Timings are a little bit flexible. We'll see how we go. And then that'll be followed by a talk on an interesting topic, which is modern management of obesity, by Dr. Rajeshwaran, who is a consultant endocrinologist colleague and also runs the London Obesity Clinic. My job throughout perhaps would be to moderate, and please keep your questions and comments coming through the chat box, and I'll try and address them either through the talk or at the end with the speaker, should we have time to spare. So I'll stop sharing, and with this introduction, I think Professor Vermani I think should kick off with his talk. And if you have any questions or comments coming through, please put them in the chat box, and we'll be dealing with it as we go along. So over to you, Professor Vermani. Thank you so much for sharing your thoughts and agreeing to be with us today to speak to our frontline doctors. Thank you so much.
My slides are visible?
Yes.
Yeah.
And I'm audible, right? Okay. Good afternoon, friends. It's good evening here in India, and I think it's afternoon in UK. My topic today is to give you an idea about the term called pre-diabetes. Some people consider it a transition state. Some think, no, it is a disease. So let's look at the complete scenario and decide at the end, what should we call it? Now, we all know that type 2 diabetes is a complex disease that progresses through 3 states, that is a normal state, a pre-disease state or a critical state, and a disease state. The key issues that I'm going to discuss today are, do all patients with pre-diabetes behave the same way? Can we identify this pre-disease state and stratify according to the risk of progression to diabetes or its complications? What drives the change from pre-diabetes to diabetes? Why is it that some patients with pre-diabetes go on to develop diabetes while some revert to normal and some stay back in that particular state? Can we prevent this change by pharmacological intervention, and whom to treat? But having said this, let me be very clear at the outset that all patients who are diagnosed with pre-diabetes, or even those without diabetes, should undergo intensive lifestyle modification. So all patients who are at a high risk of developing pre-diabetes or diabetes should undergo an intensive lifestyle intervention, period. Above that, we can discuss, but this is the basic pillar that the whole talk rests upon. Now, there are certain caveats in prediabetes. It is also known as intermediate hyperglycemia or non-diabetic hyperglycemia, and it is a high-risk cardiometabolic state for diabetes, defined by glycemic variables that are higher than the normal, but lower than what are the lower than the thresholds of diabetes that have been defined maybe arbitrarily by the various organizations. However, the current definition of prediabetes neither reflects subphenotypes of the pathophysiology of type 2 diabetes, nor is it predictive of future metabolic trajectories. In 2010, the American Diabetic Association adopted an A1C criteria of 5.7 to 6.4%. Here are the DCT units, and I believe you're familiar with the IFCC units. That will be 39 to 46 millimoles per moles for diagnosing prediabetes. So the lower bound of this criteria, whether it be 5.7 or 39, was based on the modeling of the estimated composite risk of developing diabetes and cardiovascular disease using cross-sectional data from the 2005 to 2006 National Health Survey. The glycemia of prediabetes is not independently associated with cardiovascular disease, but is said to be only a risk factor for the development of diabetes. The near twofold higher unadjusted risk for cardiovascular disease in people with prediabetes is driven mainly by abnormal levels of conventional CVD risk factors. While A1C adds minimally to CV risk prediction, those with prediabetes should have their conventional CV risk factors appropriately measured and managed. And I'll talk about it a bit later. However, there is no obvious lower threshold. Mind you, the risk starts to increase beginning at a fasting plasma of around 82 milligram per person, which would be 4.6 millimoles per liter, and progresses in a curvilinear fashion. Compared with the gold standard 2-hour glucose criteria of 140 to 199 milligram, a fasting glucose of 100 to 125 lacks specificity and results in many false positive diagnoses, whereas the A1C criteria lacks sensitivity and results in many false negative diagnoses. So there is a lot of confusion regarding the cutoffs, whether they are really true cutoffs or they are arbitrary. Now, these are the criteria in which patients you should screen for diabetes. I will not go into the details because these were meant for the American Diabetic Association or given by the WHA. But when we look at our country or the Southeast Asia, and when you look at the multi-ethnic races that are prevalent in UK, I think the answer is everyone over 30 years should be screened for diabetes. As simple as that. And especially those who are have a family history of diabetes, or those who are obese, or those women in which there is history of gestational diabetes mellitus. So these are the numbers I was talking about. 39 and 46 for your reference is what is called pre-diabetes, and a fasting of 100 to 126 or 5.6 to 7 millimoles per liter, and IGT, this is known as impaired fasting glucose, and between 140 milligram or 7.8 millimoles to 11.1 millimoles is known as impaired glucose tolerance. Now, if you look at the prevalence worldwide, in 2003, 230 million people had diabetes, and more than 300 million people were estimated to have prediabetes. It is estimated that in another couple of years, by 2025, 500 million people will have prediabetes across the world. When we look at Southeast Asia, we have the highest number of people with prediabetes, and the prevalence is going to go up to 13.5% by 2025, followed by Europe, which will be around 11%. So you can imagine the huge burden of prediabetes that is gradually growing as a slow gnawing epidemic or pandemic rather. And these are the figures that I was talking about. 37 in your case, 37 to 46 is pre-diabetes, and 6.5 A1C criteria, or 48 according to you, where is the cutoff for diabetes. What happens between 46 to 48? Well, I don't know. See, they are the problems when you have specific cutoffs, because the patients do not follow specific cutoffs. So you have to be very careful when you are diagnosing prediabetes or diabetes. And let me tell you that the two facets of prediabetes, whether it be the impaired fasting glucose or the impaired glucose tolerance, they are not clinical entities, but they are rather risk factors for diabetes and cardiovascular disease. And often they are associated with physical inactivity, obesity, especially abdominal or visceral, a, a particular type of dyslipidemia, which is high triglycerides and low HDL, with near normal LDL levels, but high, small, dense LDL, and hypertension. Now, this is what is pre-diabetes, normal glucose regulation, and type 2 diabetes. It's a continuum of dysglycemia. And you will look at various studies which have shown various rates of conversion. So if you look at how many people are going to become or convert, if you look at impaired glucose tolerance, 24% will go back to normal, 30% will remain as IGT, but 46% will develop diabetes. Similarly, with impaired fasting glucose, it will be less, 38% will develop diabetes, 38% will go to normal, and 17% will develop IGT. Now, this is a very interesting study published just, I think it was in February this year, in more than 3,400 older adults. They found, and the age was around mean age of 75.6 years. And depending on the various criteria, they found the prevalence of prediabetes anything varying from 29% to 73%, depending on whether you use A1C or impaired fasting or both as a criteria. But the progression to diabetes was, look, it was only anything between 3 to 9%. So despite being high prevalence of diabetes in older age group or elderly people, the progression to diabetes is almost insignificant. So during the 6 years of follow-up, death or regression to normoglycemia from prediabetes was more frequent than progression to diabetes. So they suggest that prediabetes is not a robust entity in older age. So above the age of 70 years, do not diagnose them as prediabetes, because that is not a high risk case. Now, we all know that higher the A1C levels in that particular bracket, 5.5 to 6.5, more the chances of developing type 2 diabetes. And besides the progression to diabetes, what else is associated? Microvascular complications. It is said usually that we have read that microvascular complications occur at the onset of diabetes. But that, my friends, is not the total truth. We have seen microvascular complications in the stage of prediabetes also. And it is said that there's a 50% higher risk of cardiovascular disease, coronary artery disease, and stroke. If you look at this normal and IGT, it is almost double the risk of cardiovascular disease. So the CVD risk is 3.2 times higher if you adjust for all the other CVD risk factors. Now, this is a latest meta-analysis published by Huang et al. In BMJ in 2020, and they looked at an analysis of more than 129 studies with more than 10 million individuals, and they found that patients with pre-diabetes had a 13% increased risk of an all-cause mortality, 15% increased risk of cardiovascular disease, 16% increased risk of coronary heart disease, and 14% increased risk of stroke. Now, let me remind you here that impaired glucose tolerance carried a higher risk as compared to impaired fasting glucose. So obviously, impaired glucose tolerance is more dangerous as compared to impaired fasting glucose. And in patients who already had atherosclerotic cardiovascular disease, the ratios were almost doubled as far as the cardiovascular disease and all-cause mortality was concerned. So pre-diabetes is associated with an increased risk of all-cause mortality and cardiovascular disease in the general population and in patients with known atherosclerotic cardiovascular disease. So what is the importance? The importance is that we must screen and appropriately manage pre-diabetes. And if we do that, that will contribute significantly to primary and secondary prevention of cardiovascular disease. Having said all this, studies have shown a prevalence of 9 to 39% of cardiac autonomic neuropathy, which is very difficult to diagnose and treat. So you can imagine in pre-diabetes, we are also seeing cases of cardiac autonomic neuropathy. And look at the long-term consequences of pre-diabetes, hypertension. There is a risk of increased malignancies by 15% involving the stomach, colorectal, liver, pancreas, breast, endometrium, and increased incidence of Alzheimer's. So pre-diabetes is also having long-term consequences. But besides all these health risks, look at the cost per capita ambulatory cost per person is increased by almost $443. So it is also costly. Now we must identify what is the problem and why it is occurring. And this is an excellent study from the main health information exchange, which has a population of more than 1 million. And they took out a cohort of around 7,300 odd patients who had developed diabetes recently. And they looked at them and they saw that there were certain patients who had a very high entropy, and during the critical period, they went on to develop diabetes. Whereas there were a lot of patients who had low entropy and they went back to normal glucose tolerance. And they fed this into the artificial intelligence system and they put them into various modules, module 1, 2, 3, and they discovered through the Markov process that what is a dynamic driver network. So they saw that there is a critical period in the transition state. And what drives this critical period to the disease is known as the dynamic driver network. So there is a critical transition, and this is detected 6 months before the type 2 diabetes is confirmed. Now, the dynamic driver network enables the identification of this particular transition state that generally has no clear metabolic abnormalities but deteriorates in the future. So we have to find what is this dynamic driver network and how can we get control it. And this brings me to the latest study published recently, again in February this year. They have identified certain clusters in pre-diabetes. Excuse me. Wagner et al. From Germany have distinguished 6 different subtypes of pre-diabetes, tracking data from an intensive 25-year longitudinal study. And each of the 6 types are distinguished by specific metabolic parameters and have different long-term outcomes. To further validate these 6 subtypes, they have also examined another longitudinal study, Whitehall 2 study, which was done in the UK, which tracked the metabolic health of 10,000 subjects over 20 years. And they found that the findings were replicated in this independent cohort based on the various anthropometric, anthropomorphic, and glycemic constructs. And this accurately fit that large data set, affirming the fact that prediabetes can be distinguished into separate disease stratifications. And let's look at this. What are this? They partitioned the variables were doing an oral glucose test, tolerance test, an MRI which measured the body fat distribution, liver fat content, and they looked at the genetic risk in a cohort of extensively phenotyped individuals. And they found that there were 6 clusters. Cluster 1, 2, and 4 had low risk of diabetes and low mortality. In fact, 1 was underweight, 2 was normal weight, and 4 was overweight, but all had metabolically healthy biomarkers. If you look at cluster 3, this was a high risk with low insulin secretion. They had a very high genetic risk. Besides having a high diabetic risk, they had a very high cardiovascular and nephropathy risk. When you look at cluster 5, they had again high risk, but they had a lot of liver fat and insulin resistance. So they had high cardiovascular risk, high nephropathic risk, and higher mortality. And the cluster 6, again a high risk case, had a higher visceral fat, high renal sinus fat. They had high risk of nephropathy, higher mortality, but surprisingly, their risk to progression to diabetes was very, very low. Perhaps they were genetically protected as far as the risk to develop diabetes was concerned. So this proof of concept study shows us that there are basically 2 groups of patients. One, in which there is an increased risk of complications without rapid progression to overt type 2 diabetes. And number 2, who have both an increased risk of complications and they also rapidly progress to overt diabetes. And this clustering approach may not be designed for a clinical setting, but it is very helpful for characterizing the metabolic heterogeneity prior to clinical manifestations of type 2 diabetes. And this has potential therapeutic implications, which I will discuss in the end. We must accept certain limitations of this study. It has been done in the Caucasians. We do not have the data for the different ethnicities and races, and the variable selected for partitioning approach may not be the ideal or may not be feasible in every center. And unfortunately, there were also high attrition rates in the study. But having said that, this does give us a very, very important clue that all prediabetes do not behave similarly. So having given you the data behind, how do we approach the patient? It is very important to assess these patients. We want to know what the patient already knows, and what he understands or misunderstands right at the start of the discussion. What does the patient want to know? Assess the patient's desires, his or will be able to comprehend additional information, whether is able to understand the meaning of prediabetes or the difference between prediabetes and diabetes. And what is more of concern or importance to the patient? He may not be bothered of nephropathy or a heart attack occurring 20 years down the line. Or women who are contemplating pregnancy, you have to give them the facts that uncontrolled blood sugar, even in the pre-diabetes stage, can lead to birth defects. And we have to tailor the information desired according to the level so that it improves comprehension and limits emotional distress. That is very important. We don't want to create so-called diabetic distress in patients of pre-diabetes. We must evaluate the spectrum of predisposing risk factors. If you find one risk factor, say obesity, look at the others, whether he is smoker, whether he is hypertensive, whether he is dyslipidemic. So you have to look at it comprehensively at each and every risk factor. Talk to the patient about the disease. Take him into confidence. He is going to decide the treatment. involve him into weight loss, how to increase activity, how to eat healthy. These are the things which I said are very important for an intensive lifestyle intervention. If needed, refer them to other members of the healthcare team, maybe a dietitian, maybe a counselor, and use tool and other resources of educational information. Now, when we look at the management, there have been various studies regarding the lifestyle interventions as I talked about, and I don't want to go into the details, but let me tell you that lifestyle intervention continues to have an effect even after 20 years. When we look at the pharmacological interventions, again, the metformin has scored quite well, but when we look at that, there may be adverse effects with some drugs. Now, ACNO study talks about pioglitazone, and it showed an 81% risk reduction. I don't know whether you use pioglitazone in UK or not, but we are very prolific users of pioglitazone in India, but at very low dosages. Now, treatment with pio in patients with IGT reduced the risk of diabetes, although pioglitazone was associated with significant weight gain and edema. Treatment of 18 patients for 1 year prevented 1 case of diabetes. Besides that, there were improvements in diastolic blood pressure, HDL cholesterol, liver enzymes, and slowed the progression of carotid intima media treatment. So it has to be used very judiciously, and I'll talk about that. There have been a lot of other drugs which have been used in the prevention of diabetes, including linagliptin, which is a DPP4 inhibitor, a GLP-1 RA like liraglutide. But I will talk about one drug, DAPA. Dapagliflozin, an SGLT2 inhibitor, was used in patients without diabetes, without pre-diabetes, and they found that there was 32% relative risk reduction in the development of pre-diabetes or diabetes. But having said all this, if you look at the comparison between lifestyle and metformin, 31% reduction by metformin, 58% reduction by lifestyle. And the cost of lifestyle interventions is hardly $1,000, whereas the cost of metformin is around $31,000. Now, this was the diabetes prevention study I was talking about. Then came the diabetes prevention program to see 850, 100 milligram twice daily. The patients were unmasked and they wanted to see who benefits. And they found that who benefited? Patients who had a higher baseline of fasting, that is 110 to 125 versus 100 to 109, or with an A1C level of between 6 to 6.4 versus less than 6, or in women with history of GDL. So if you are looking at management strategies for treating pre-diabetes, of course, you have to stratify the risk as I talked about. Metformin in the higher A1C criteria, and maybe even metabolic or bariatric surgery if the patient has a BMI of more than 40 kg per square meter with no risk factors, or more than 35 kg per square meter with one or more obesity-related factors. Now, there are a school of thought which says no need to treat pharmacologically. It is a transition state. And what do they have to say? They say that association between pre-diabetes and cardiovascular disease is due to the non-glycemic risk factors in people with pre-diabetes, not due to slightly increased glycemia. The only reason to treat with metformin is to delay or prevent the development of diabetes. And they give 4 reasons not to treat with metformin. 2/3 of the people with pre-diabetes do not develop diabetes, even after many years. 1/3 people with pre-diabetes return to normal glucose regulation. And people who meet the glycemic criteria for pre-diabetes are not at the risk of microvascular complications. That is a school of thought. And metformin does not fundamentally change the pathophysiology of prediabetes. So they say that why give metformin unnecessarily to these patients who are not at the risk of microvascular complications just to lower the subdiabetes glycemia to even lower levels. But having said this school of thought, let's look at the other side of the coin. And I believe in this side of the coin that prediabetes is a disease because hyperglycemia is a continuous risk factor for adverse health outcomes. Both the degree and duration of hyperglycemia are associated with the development and progression of diabetic microvascular and macrovascular complications. And there is a delay of 3 to 8 years between the onset and diagnosis of type 2. Now, at the time of diagnosis of prediabetes, 8 to 16% of patients have diabetic retinopathy. 17 to 22% have microalbuminuria, and 14 to 48% have peripheral neuropathy. And these are the microvascular complications which we thought develop only after these patients develop diabetes. And this is a recent epidemiological analysis from your country, UK, and it has shown that patients identified with prediabetes had a high risk 1.76 for retinopathy and 1.14 for nephropathy. And this is another study, the CORA study, which showed that prediabetes associated with microalbuminuria, reduced kidney function, and chronic kidney disease in the general population. So why metformin was chosen? Because potentially provided an 8% absolute reduction in the risk of development of type 2 diabetes over 30 years. And this reduces the cumulative lifetime glycemic exposure, delaying or preventing the development of complications and their attendant decrements in the health related quality of life. It is inexpensive, and it both reduces cost and improves health outcomes. So it is reasonable provided we have selective use of metformin in individuals with the greatest likelihood of benefit. That would even result in greater cost savings. There are many supplements like cinnamon, chromium, alpha lipoic acid, beta melon. They have been specifically marketed for diabetes and diabetes prevention. Allowing marketing and sale of these unproven therapies for diabetes and denying high-risk individuals metformin is a proven side effect, effective and cost-saving treatment is totally irrational. So we must remember who will benefit with metformin: patients who are less than 60 years of age, a BMI of more than 35 kg per square meter, those who have greater degrees of fasting hyperglycemia, and women with history of GDM. And this is what is called benefit-based tailored treatment because it calculates an individual's absolute risk reduction as the difference between the individual's risk without treatment and with treatment. So you must know which patient to give metformin. There has been a lot of talk about vitamin D, and this was a wonderful double-blind randomized trial where 4,000 international units vitamin D3 was compared with the placebo in more than 2,400 overweight or obese individuals with prediabetes. It was seen that progression to new onset diabetes was not significantly lower with vitamin D as compared to placebo. So this was not statistically significant. So vitamin D does not prevent the the promotion of prediabetes to diabetes. Now coming back to the therapeutic implications of the clusters in prediabetes I talked about. Now, as I said, that there are patients who are associated with renal disease and elevated mortality in cluster 6. So it is very important that we must take care of that even when we know that the progression to diabetes is very, very low. Now, what are the drugs that can be used in prediabetes? The only drug approved so far by the FDA is metformin. So metformin in cluster 3 and 5, definitely, because they have high risk of progression to diabetes. But in cluster 6, the use of metformin may be doubtful because low risk of progression to diabetes. But let us look at some of the off-label drugs, which are very good but not yet approved. I talked about pioglitazone. We know that it can reduce the cardiovascular risk. It has role in clusters 3, 5, and 6, but you have to use it judiciously. Then we have another drug called saroglitazone, and this is basically an Indian drug, and there is sufficient and lot of emerging evidence that it can reduce adiposity, it can reduce the liver fat content, and it can reduce the cardiorenal complications. Then, of course, we have the SGLT2 inhibitors, which have a very high potential, especially in clusters 3, 5, and 6, because of their known cardiorenal protection. And I'm sure these drugs are going to be approved very soon, even for pre-diabetes. But all, besides having all this, whenever you are using an off-label drug, remember certain thumb criteria. Judicious selection of patients. Don't use it rampantly. Use it when there is no contraindication. Share decision-making with the patient. Educate the patient and be pharmacovigilant for any side effects. So friends, to wrap up, what are the key messages? Pre-diabetes needs to be further classified for risk stratification. Not all patients behave similarly. Strategies to screen for pre-diabetes and assessment of individual risk factors is the need of the hour. All patients with pre-diabetes should be counseled for intensive lifestyle modification. Clustering of pre-diabetes is a very novel and emerging concept. We must know where to use metformin, younger, more obese, more hyperglycemic, history of GDM, or cluster 3 and 5. And looking beyond the guidelines, remember the two drugs, pioglitazone and SGLT2 inhibitors. They can be of immense benefit in cluster 3, 5, and 6 to prevent the cardiorenal complications. So dear friends, in the end, do not ignore the inner fire of pre-diabetes. Thank you for a patient hearing.
Thank you. Thank you, Professor Vimani, for such a wonderful presentation and actually covering, right from the start, definitions. Particularly fascinating was the diabetic distress, in discussions with the patients. Cutoff wise, I think we are awaiting nice guidance at some point this year, who might take into account the international criteria of 39 rather than 42, which is used in this country as of today, and often it's an ignored concept, as you rightly said. The clustering is so fascinating. I think a lot of some very up-to-date information, which I'm sure people who were listening in to would take home and will have time further to look at your, listen to your talk again and digest all the information. Pioglitazone, I'm sure you'd be aware that it's not approved in UK and was taken off because of concerns for cardiovascular risk, if I'm right in thinking, and Smita might correct me on that. Yes.
We still use pioglitazone.
Right.
Rosiglitazone was taken away.
There was the Rosi, so one of the glitazones was taken off.
Yes.
Pio must have stopped because of the concerns of bladder cancer, but then they were later proved to be not true.
Sure.
Yes, and in worsening heart failure, Dr. Virmani, as well. Yes.
That's why we say judicious selection. We can't see patients with incipient heart failure.
I think going forward, the most exciting prospect is going to be the flozins or the SGL2 inhibitors, which have been approved internationally to in pre-diabetes patients, and that is going to be fascinating to see how much mortality or end organ disease risk they provide going forward. So I must thank you for your wonderful deliberation. Are there any key questions coming through? Please, we have a few minutes are there any questions at all? I'm sure that there's a lot of information from Dr. Virmani's talk. It'll be available to view as many times you want to virtually after a week or so. But I'm sure everyone would appreciate this is something which we all need to recognize. I think in our practice, we come across, I come across personally often random HbA1c values which might not have been looked at and patient might not know. And then suddenly I tell them that you have something called pre-diabetes, and they get a shock, and you got to deal with that. As you said, diabetic distress, that no one said that to me, that I had something called borderline or pre-diabetes. So, and I think there's a question or a query that why do we not routinely use more robust methods of diagnosis routinely? Or why are we using HbA1c when OGTT is evidently more reliable? So that perhaps brings to the question of which one works where. Any comments, Dr. Virmani?
Yeah, of course, OGTT is the gold standard, but unfortunately, it is a cumbersome procedure and it is not feasible to do in routine clinical practice. On the other hand, a HbA1c, you don't need fasting, you just need a prick, and you get the results within an hour or so. And it's very easier and I think very convenient to do an A1C than going for an OGTT. But then for diagnosis also, an A1C may not always have, it's got its limitations, as I said, it may be false positive or false negative. So the ideal is to get a fasting plasma glucose done, a 2-hour OGTT postprandial done, and also an A1C. And then,
am I right in thinking that fasting plasma glucose is the most accurate of the 3 tests?
no, fasting is not the accurate, but it is the most convenient.
Right.
The accurate is the postprandial, because when we look at the natural history of progression of glycemia,
Sure.
we see that the postprandial rises first,
Right.
and then the fasting.
Right.
So if we do fasting only, we miss that small segment in the early stages where the postprandial rises first.
Fantastic. That's really, yeah, that reminds me that the post-glycemic response is perhaps the most relevant. And thank you for that, sir. There's another question. Do you think the criteria for diabetes should be changed in over 70s if the pre-diabetes threshold should be different as per you showed from the very recent study?
Absolutely. I totally believe that we cannot have one criteria across the world. We have to have different criteria based not only on ethnicities and races, but also on various age groups.
And do you agree that pre-diabetes is more of a worry and concern in younger age group than someone who might have a prognosis of 20 years, or let's say from 70, 80 onwards?
That's what the studies have shown, that after the age of 70 years, the patients are more likely to die because of other reasons than development of diabetes, the progression to diabetes. So it is younger age group where they have a long span of life, and the chances of developing diabetes and its complications are much higher. So we have to be very careful, especially in the younger 20 years, 22. We are seeing patients in the age group of 20, 22 years who are obese and they are pre-diabetes. So we have to be very.
I mean, that is not surprising. I mean, I can share with the group here. I recently had a 28-year-old who had an acute coronary event, and the HbA1c was 46. It was just done randomly on the point of at the point of admission, and it was ignored. And of course, someone would have looked at carefully, would have thought that this chap must have had a ongoing cardiovascular risk for some time. So I think there are lots of lessons to be learned from this, and I'm sure the NICE guidance would perhaps formalize all that. We hope at some point this year. It was expected last year, to be updated. It's long awaited. So with that, we close with your permission. And
just a question, Professor Birmani, how low threshold do you have to treat pre-diabetics? Do you treat your pre-diabetics or just give LSM?
No, as I said, we have to have a very narrow window where we really pharmacological treat. We are the younger patients who are obese or women with history of GDM or very high fasting plasma levels in the range of say 120 to 125. So I will treat those with metformin, but rest all I will put them on intensive lifestyle modification and follow them every 3 months to see whether they are really following intensive lifestyle modification or not, and they're getting the therapeutic results.
So following on from that, Smita, what is the current, just in one short line, if you can summarize, what is the current policy of managing pre-diabetic patients if you identify and read code someone as pre-diabetes as per the current NICE criteria, which is 42, mind you, not 39? Thank you.
So if we have anyone with A1C of 42 to 47, they then get referred to, there's an NHS diabetes prevention program, NHS DPP. It's like an educational program, and they get all the lifestyle modification advice from there. Obviously, they're not treated pharmacologically, but then in primary care, we do, based on their A1C, if it's like 46 or 47, we will repeat it in 6 months. Otherwise, they get an annual A1C.
Thank you. Thank you very much. Thank you, Dr. Ramani, for your wonderful talk. And over to Smita for your case-based learning in diabetes, which should be perhaps in continuum from what we've learned so far. So have you got the sharing thing? Thank you.
So are my slides visible?
Yeah.
Okay. 2 seconds. So Professor Birmani, after a lovely pre-diabetes, which is obviously going to be the burning topic very soon. And as we said, we were expecting a NICE guidelines in December last year, but obviously it's been delayed. So welcome everyone. So I'm a GP and have special interest in diabetes and cardiovascular disease. So I will be talking about management of type 2 diabetes. It will basically be a case-based learning. So will be interactive. You can either raise your hands or put a comment in the chat box, and we will take it from there. So I will be talking on discussing this case, oral diabetic agents, diabetic injectables, very briefly on the insulin, because as FY2s in the secondary care too, you are not expected to be dealing with insulin. There will be specialist diabetic nurses who will deal with it. And some of my resources, also in insulin in the primary care, if you get a task from the district nurses about, then you will have enough supervision and support to deal with it. So you're not expected to know a great deal about the insulin, but I will touch on it very briefly at the end. So you have a telephone consultation booked in, considering the pandemic, for, it says on the appointment, tiredness and lethargy. When you take a history, you find out that he's a 53-year-old gentleman, Asian male, he's non-smoker, otherwise fit and well. He works in a bed factory and presenting with few weeks history of tiredness, lethargy, fatigue, increased thirst, increased appetite, and weight loss. What are the relevant points in the history that you may wish to explore?
There's nothing in the chat box
Okay.
so far.
So obviously we know he's a non-smoker. We need to know a few more things. What's his lifestyle like? We know he's a non-smoker. Is there any alcohol history? We would like to know about the dietary history, exercise, family history, very, very relevant, and whether he's taking any over-the-counter medications. So once we've done the telephone triage, we've got a relevant history. What do we do next? Anyone?
Bring him in, dip his urine as a start point.
Okay, yeah. Anything else? Obviously, considering the pandemic, you will bring the gentleman for a face-to-face. Yeah. And what would you like to do?
So there's a comment, needs bloods.
Yes, yeah. Anything else?
There's another comment, needs HbA1c,
Yeah.
DFTs, FBCs, use need LFTs, so routine bloods basically. Yeah.
Yes. And what about examination? Okay, so
Blood pressure.
yes. So we arranged for a face-to-face. It comes out that his BMI is over 35. His blood pressure is 144/90, and that's the third reading. So any of you who would have done primary care will realize that if the clinic blood pressure is high, we do three readings a minute apart, and then we document the lowest of the three. So his clinic blood pressure is 144/90. He has a heart rate of 78. His chest, cardiovascular, fundus, feet check, they're all normal. So we had some about the investigation. Of course, we'll do some bloods. Anything else you would wish to do considering his blood pressure? Yes, ECG, I can see that. Anything else? Okay.
Urine dip.
Yes. So we need a full blood count, USNEs, eGFR, thyroid function test, LFTs, lipids, and A1C. Considering his clinic blood pressure is high, he's got possible hypertension. While we are investigating, he needs an ECG and he needs a urine for albumin creatinine ratio. We ensure it's the first sample of the day in a white top bottle. We used to do ambulatory blood pressure monitoring, but due to the pandemic, we do not do them anymore. So we have a chart which we give to the patients if they are happy to do home blood pressure monitoring. So they take 3 readings in the morning, 2 in the morning, 2 before tea time, do it for 2 weeks, and then bring in the chart for us to review. So once we have done all the investigation, we await for the path results. Now we have the reports here. So his full blood count, LFTs, TFT, USNEs are normal. His total cholesterol is 6.8, HDL is 1.2, LDL is 3.2. His QRIS2 is 15%, eGFR of 75, HbA1c of 60. And his home blood pressure monitoring shows several readings above 135/85. So what is the diagnosis here? Type 2, that's right. Do we need to repeat his A1C? We have a 53-year-old gentleman who's symptomatic and who has an A1C of 60.
So in terms of diagnosis, you've got type 2 diabetes, hypertension with end organ damage.
Anything else? Look at his lipid profile. That's right. Yeah. Okay. So, yes. Do we need to repeat his A1C?
Type yes or no.
No, that's right. Someone who's symptomatic with one reading of in the diabetic range, we do not need to repeat. We only repeat in those who are asymptomatic. Okay. And what is the relevance of QRIS2 here? His QRIS2 is 15%. He has got hypercholesterolemia. He needs a statin. Perfect. Do we know what is QRIS3? Okay. So QRIS2 is a risk stratification which takes into account your age, your sex, your systolic blood pressure, your ethnicity, and your postcode. And it gives us a percentage. If it's over 10%, it's relevant, and they need a statin. Considering the QRIS3, it takes into account severe mental illnesses because they have been considered to be high risk for cardiovascular disease. So they take into account your mental health and not just the systolic blood pressure, but it takes into account a range of blood pressure. Though it's not available on our system 1, so we still use QRIS2, but you can go on online and calculate the QRIS3 for the patients. And what are the conditions? Any conditions where we should not be using A1C to diagnose diabetes? Yes, hemoglobinopathy is right. Anything else?
Pregnancy?
Yes. Okay. So as we said, this gentleman has got type 2 diabetes, has got hyperlipidemia, and he's got stage 1 hypertension. Okay. As Dr. Birmani, in his wonderful talk, he mentioned about pre-diabetes. So as per NICE, 42 to 47 of fasting plasma glucose of 6.1 to 6.9 is pre-diabetes. Anything 48 or over or 7 and over is diabetes. And we've discussed anyone symptomatic with just one reading or one A1C or fasting plasma glucose is needed to confirm the diagnosis. In asymptomatic individuals, we repeat it at least 2 weeks apart. So A1C should not be used because the results can be spuriously high in renal diseases, hemoglobinopathies, pregnancies, HIV, severe anemia, pancreatitis, and recent blood transfusion. So now we have a diagnosis for this gentleman. What is the initial management? What would you do for his diabetes, his hypertension, his hypercholesterolemia? So I'll come to that very quickly. These are the symptoms and signs. Most of us know about it. A lot of them will be asymptomatic.
So we got a response here: lifestyle, metformin, statin, ramipril.
Perfect. Yeah. Polyuria, polydipsia, polyphagia, the trial, weight loss, and frequent UTIs or thrush. In type 2 diabetics, there is decreased production of insulin by the pancreas, and there can be insulin resistance or a combination of both. The main difference between type 1 and type 2 is the pancreas are still producing some insulin in type 2. And type 2 is more common in over 40s, obese, family history, ethnicity, South Asian, or Afro-Caribbean. 1 in 11 adults worldwide will have type 2 diabetes mellitus. On an average life expectancy among those is less than 10 years than those without. And The reduced life expectancy is due to the microvascular complications, atherosclerotic cardiovascular disease, nephropathy, and retinal disease. So initial management, as I said, he needs a lifestyle modification, he needs a statin, he needs ACE, he needs metformin. And he needs a referral to Desmond as well for diabetic education. We ensure that he's put on practices diabetic register. There is an annual recall in place. Referral to the local retinal screening service, very important. We ensure he has good foot care, lifestyle advice, weight management. Dr. Raj will be talking in detail about diabetes and weight management, so I'll leave it to him. Medications, we know what he is to have. So coming to this slide, anti-diabetic medications, we have metformin, we have sulfonylureas, DPP4 inhibitors, and pioglitazone. Mechanism of action, both metformin and pioglitazone, they act by increasing insulin sensitivity. Sulfonylurea, they target the B cells to cause increased insulin secretion. And DPP4 inhibitors, they inhibit DPP4. Glucose-dependent insulin increases and decreases glucagon. Metformin has cardiovascular protection. Sulfonylureas and pioglitazone, they have good glycemic control. And DPP4 inhibitors, the glucose-dependent insulin production. Main side effects for metformin is GI side effects. If the patient is getting it, swap them to modified release, very well tolerated. Lactic acidosis, very rare complication. SUs, weight gain and hypos. DPP4, rash, pancreatitis, GI side effects, headache. Pioglitazone, as we discussed earlier with Professor Birmani, that there is increased risk of bladder CA, risk of fractures, and exacerbates heart failure. As someone said very rightly, we start metformin and up titrate, start on ramipril with close monitoring of blood pressure, use and ease at eGFR, and commence atorvastatin 20. Once we've done this, we bring them in with to see the practice nurse to review the blood pressure and repeat use and ease eGFR 2 to 3 weeks. Why do we need to do that? Okay, so because we are starting them on ramipril, that's right, yeah. So you need to ensure that if the patient has renal artery stenosis, it will worsen very significantly. So we need to ensure once we start an ACE, we repeat and use an eGFR in 2 to 3 weeks. And then we have a plan to do an A1C in 3 months. So interestingly, this patient now missed a DNA 2 invites for repeat A1C blood pressure check. Now 6 months have passed. Then you get a discharge summary mentioning that he's been admitted 2 weeks ago with acute coronary syndrome. A1C is now 80. He is on cardiac meds for NSTEMI. And it mentions GP to review diabetic medications and control. His blood pressure is 140/90, heart rate of 74. He's been started on ramipril 5, bisoprolol 2.5, aspirin, ticagrelor. Atorva has been increased to 80. What do we do next? So his diabetes is poorly controlled, suboptimal blood pressure control, and he's had an event. Okay. So in terms of managing type 2 diabetes, we have monotherapy, which this gentleman is already on, metformin, and then switch to modified release if side effects, if contraindicated or not tolerated. You can either use SGLT2s, DPP4, sulfonylurea, or glitazones. Once they're on a single agent and you have to optimize his medication, you can add any of these. Obviously, you do not use SGLT2 and GLP-1 because the mechanism of action is the same. And at the same time, you do not use a pioglitazone and SGLT2. So obviously, he has not been compliant to his medication. He's not attended his reviews and ended up having a microvascular complication. So we have to emphasize that he needs to take his medicines regularly. Considering the second agent, I would like to go on to so this is the American Diabetes Association latest guidelines, came out in January this year. So someone with atherosclerotic cardiovascular disease, they need an SGLT2 or a GLP-1. So if we follow these guidelines, this is the one we should put him on. So he declined injectables. So he was started on SGLT2. His ramipril was up-titrated, aiming for a blood pressure of 130/80, and his bisoprolol up-titrated to max tolerated. And a plan was made to repeat his A1C in 3 months, check his lipids, UANEs, eGFR, and ACR in 3 months as well.
So there's a comment from Dr. Vermani, and I think it's quite pertinent that, and it may have happened, which you might not know, because all you might get is discharge summary. That what Dr. Vermani suggests, that ideally the patient uncontrolled hypoglycemia in the setting of ACS
should be started on GLP-1, yeah.
Should be controlled with insulin, and preferably a GLP-1 RA.
Post-discharge.
And I think, I'm sure in the setting of ACS, whilst he had been on CCU, he would have been
on insulin. He must have been on insulin as an inpatient, yeah.
As per the protocol, and at some point
Yes.
have been switched over to his usual oral therapy. So it is a problem, which I have to admit in our practice, because patients are being discharged too soon these days, of course, due to the rapid turnover of ACS patients from the hospital. STEMI patients are discharged in up to 48 to 72 hours, actually. And there's hardly much time to address the comorbid conditions.
That's right. And the rehab team, they're more focused on the blood pressure and the heart rate than the diabetes side of things. And it gets left to the GPs to do it. So obviously he was offered GLP-1, which he declined. And so he was started on an SGLT2. Thank you, Dr. Birmani. So further 3 months down the line, his A1C has now come down to 70. His blood pressure is slightly improved, though not optimum. Heart rate 76. He's now on ramipril 5, bisoprolol 5, not able to tolerate any higher, not getting any angina symptoms. Lipids slightly improved as well. eGFR mild decline. Now he's got proteinuria. What next do we do? Okay, so considering his HbA1c is still high, he's on 2 agents, we need to add a third agent. So third agent, as you see on here, metformin with any of the 2, metformin, these agents, and the fourth line is metformin, sulfonylureas, and GLP-1. Going by the ADA chart that I showed you earlier, I think he qualifies now to go on to GLP-1. So further on, when he was started on GLP-1, his A1C reduced further to 60. So he's now on metformin 1 gram, AMPA 25. His blood pressure is to target on ramipril 10. His heart rate is 68 on 5 of bisoprolol. Not getting any angina symptom, on aspirin, ticagrelor. BMI has come down. He's back in work. He's been discharged from cardiac rehab team. He's had a follow-up in cardiology outpatient where he had an echo and his ejection fraction was 55%. So going by the same guidances, the ADA guidance, someone with heart failure, SGLT2, which he is already on. So the next line for him will be a GLP-1. So glyphosins and GLP-1s injectables, they bind to GLP-1 receptors, they increase the insulin secretion, decrease glucagon production, and delayed gastric emptying. Very good glycemic control, they help with the weight loss. There are weekly injectables available now, which is very convenient for patients. GI side effects, pancreatitis, we do not use them, and those with teratogenic is not used. So glyphosins, these are the SGLT2 inhibitors, excretion of glucose in the urine, reduce blood glucose, they increase the frequency of thrush and UTI, DKA, and increased risk of lower limb amputation due to infection. We now have the game changer, the oral GLP-1, which is used as an adjunct to diet, exercise to improve glycemic control. It is not recommended as the first line, and those with pancreatitis are over 75s. There is a risk of medullary thyroid carcinoma, or MEN2. So the patient needs to be counseled for the risk and look for signs like mass in the neck, dysphagia, dyspnea, persistent hoarseness. It also tells us that routine monitoring for serum calcitonin or thyroid ultrasound scan is of uncertain value for early detection of medullary thyroid carcinoma. So his anti-diabetic medications have optimized. We've already added in a GLP-1, whichever he goes for, either injectable or oral. Oral is available on NHS to prescribe. So up titrated his ramipril lifestyle. Going by the treatment targets, for anyone with just on lifestyle control, we aim for an A1C of 48. Lifestyle and one drug, A1C of 48 as well. Those using drugs with hypoglycemic side effects, we aim for an A1C of 53. If it's over 58, we do consider escalation of therapy, provided there's no hypoglycemia. Further 3 months down the line, so we're making him better. He's improving in terms of his lifestyle, his numbers. His A1C is 53 now. His ACR improved, still mild proteinuria. He's tolerating all his medication. He's okay with injectables. BMI is down to 26 now. And we ask for a repeat bloods at 3 months, and with safety netting advice to seek medical help, symptomatic of hypoglycemia, side effects of angina. He's on 3 agents, which is the fourth agent that you will use. So it will be sulfonylureas in his case, because he's got a low ejection fraction, so we will not go down the pioglitazone route.
Does he need a fourth agent?
Considering his A1C is 53 and his microvascular complications, it's obviously his choice. If he wishes to have tighter control, we can offer him a fourth agent. So he's tolerating all the medications very well. You could add in a low dose of sulfonylureas, mainly because he is on GLP-1. So high dose sulfonylureas with GLP-1 can increase risk of hypoglycemias. And because if you start him on sulfonylureas, we need to ensure that he monitors his blood sugars before breakfast, before evening meal, and aim for a BM of 5 to 8. We come to this chart, we've discussed about atherosclerotic cardiovascular indicators, GLP-1, SGLT2, those with heart failure, SGLT2, those with CKD, SGLT2 inhibitors. So, and if there is compelling need to minimize hypoglycemia, we have these agents. I will share this document with everyone for everyone's reference. It's really, I quite like this, and it's really nice to follow, easy to follow as well. In terms of insulin, so you either, if you need to add them, you add a basal insulin and start at 10 international units a day, or 0.1 to 0.25 international units per kg per day. And then repeat, increase by 2 units every 3 days. Aim for a BM of 5 to 8. These are some of the resources. Thank you for your patient listening. Any questions?
Thank you, Smita. Are there any questions at all? Please type or speak. Speak up, please. If there are no questions, then thank you very much, Smita, for your wonderful journey of what have been a real life case. I'm sure the patient eventually got to a reasonable level of control. Dr. Vimani has a comment.
Yeah, I just want to know, do you start statins in all patients with diabetes, irrespective of the LDL levels in UK?
It's if their Q risk is over 10%, Dr. Virmani, then we start them on statin.
Okay, okay.
So just to put that in context, that's, I mean, like Framingham and a few other risk calculators, it's freely available. It's been population tested and validated. The versions have evolved over the years, and now we have, which you can just Google, Q-Risk 3, which is the latest version. It takes into account mental health because that's now a recognized cardiovascular risk factor as well, along with average blood pressure reading. So it's slightly better than Q-Risk 2, although in UK NHS scarce as of today. The computer systems which run System 1 have Q-Risk 2 built in. I think it'll be a while. It's a funding issue until it switches over to Q-Risk 3. But Q-Risk 3 can be done easily for someone you're worried about. It'll tell you a 10-year risk of CVD, and then accordingly, if it's more than 10%, then you qualify for a primary prevention statin, which usually is atorvastatin 20 milligram once a day. And there is a comment here. Can you interpret Q risk in diabetic patients? Yes, I think.
For primary prevention, yes.
Certainly. Whereas a school of thought, if you had to go really by some international guidelines, Dr. Vimani, and people would agree that diabetes on its own is considered as a CAD equivalent condition, and it's a chronic inflammatory disease, as it said, affecting the blood vessels. So no matter what the level, no matter what, simply the word diabetes itself qualifies for primary prevention, which as a cardiologist, I would support wholeheartedly. Thank you.
And another thing, Q-Risk score is the only risk score that is validated in Asian Indians. The Framingham has not been validated.
Yes, and just to update a little bit, Q-Risk 3 takes into account all ethnicities,
Right.
From a UK perspective, and I think it provides a peace of mind and a rationale to the patient, and that partnership approach why they are on statin, because not everyone agrees with the statin, and also even a 20 milligram statin can be a nightmare for someone, where you're expecting them to take 80 milligrams if they're needed for secondary prevention. So I hope that addresses the query. Thank you so much. So we'll just have 8 8-minute break while we set up with our next speaker.